Well, good afternoon, everyone, to those online as well as those here in the auditorium. We will allow a few more minutes for folks to come on in, and whether it be online or in the auditorium. Um, while we're waiting, I would like to cover a housekeeping item that I've been asked to do. Just remind you all that are online to use the Q&A function and not the chat function. When the time comes for us to do the Q&A, just remember, those of you here in the audience, just raise your hand and someone will bring the microphone around to you. That way we're sure to catch everything so the interpreters are able to capture our entire session. Well, thank you all for joining us this afternoon, this hazy gray afternoon. We're honored to have with us Dr. LaVerne Haynes Collins, and she is the owner of New Seasons Counseling, Training, and Consulting. She provides counseling services in Virginia, Georgia, North Carolina, and South Carolina. Dr. Collins is an author, speaker, ordained minister, and award-winning mental health trainer with special interest in multicultural responsiveness, organizational dynamics, and faith-based competencies. Her work has been published in Counselor Magazine, Counseling Today Magazine, Authority Magazine, USTimes.com, Women's Insider, and several counseling textbooks and multicultural counseling encyclopedias. Dr. Collins is also the author of the book Overlooked, which I am holding here in my hand. It's a counselor insights for the unspoken issues in Black American life, which made the list of recent books of interest to African American scholars in the Journal of Blacks in Higher Education. And that was from December of 2023. As one of the foremost leading trainers on the intersection of race, faith, culture, trauma, and mental health, Dr. Collins is changing the status quo of mental health and service delivery by equipping mental health professionals who want to specialize in cultural sensitivity and mental health. This year, I think it was last year, her work earned her the attention of USA Leaders magazine, who named her as one of the top influential healthcare leaders in the USA to watch. That was for the year 2025. Dr. Collins has a dual bachelor's degree from Syracuse University. So she's not shy to this weather. She's aware of the weather that we're having. One day nice, one day not so nice. And an MS in education in community counseling from, and I can never pronounce this, Duquesne University in Pittsburgh. In addition to a PhD in Christian counseling from South Florida Bible College and Theological Seminary. Please join me in welcoming Dr. Collins.
Good afternoon, everyone. And thank you, Chanel, for not just the wonderful introduction, but the splendid hospitality and the invitation itself. Thank you. Thank you. Well, in the interest of full disclosure, as I speak to psychiatrists and psychiatric residents and psychiatric nurse practitioners, I got to tell you where I fit on the continuum of care. I am not a psychiatrist. I am not a psychologist. My specialization is in counseling. So it's quite humbling for me to sit in your presence today and share with you. From a counseling perspective, my doctoral degree is in Christian counseling. I wanted to take a faith-based approach for a couple of personal reasons, because coming from a faith-based community, I recognized that oftentimes there are misunderstandings and biases around mental health care and people struggling with whether it conflicts with a particular faith belief. And I wanted to be able to integrate, meet people at the intersection of their faith and human understanding of theology and higher power, spirituality, and religion for those that preferred counseling services from that perspective, and intersect what I would call with the heart and mind of deity with the heart and mind of humanity. So that's the perspective from which I come. That's the perspective that from which I was trained. So I appreciate your your time today, your trust in a counselor to speak to you. Now, what I will also add is that my specialization as a counselor is really at the intersection, if I can use that word, the intersection of sociology and mental health. So I focus on how issues of race, faith, trauma, and culture intersect with the identities of marginalized, otherized, and racialized populations. So that's the perspective I'm coming from today. My practice, my business is New Seasons Counseling, Training, and Consulting. And I provide counseling services, I provide continuing education training, and I also run the trainer program to empower and build and help develop other counselors who desire to be trainers in the area of continuing education for the counseling profession. And this year, I'm pleased to say that in May, we are celebrating 15 years as New Seasons Counseling, Training, and Consulting. I started when I was 2. Talking today about culture in clinical and community mental health. I want us to think about contextual clues in clinical care. And our objectives today, we have to have learning objectives for continuing education credit, is first to describe how cultural and community context can influence. There's an unspoken, often unrecognized influence on symptom presentation, description and interpretation, on treatment engagement and patient communication. We've got to understand how these factors, like I mentioned, of race, faith, culture, and trauma influence what happens in clinical care. We want to identify the clues that any provider, counselor, psychologist, psychiatrist, social worker can use as clinical information when you're thinking about case conceptualization, assessment, supervision, diagnosis, treatment planning, all those things. We want to apply concise inquiry strategies. Like, how do we make the inquiry? How do we find out about some of these things that people are often reticent and reluctant to talk about? How do we ask? How do we broach? Because we want to have relevant cultural and community information, but we don't want to disrupt the clinical workflow. I actually believe that it's not a disruption to clinical workflow, but it is critical to clinical workflow. And then we'll talk about recognizing opportunities to bridge clinical care with community experience to support engagement, to support alliance, and of course, to support recovery. So the first question, and can I actually invite anyone to speak? I'd love to hear your thoughts on this. Please share, if you would, your personal opinion about whether culture should be background content or foreground content in treatment. Now, when I say background content, I'm speaking of after you speak of the symptomatology, after you speak about other kinds of presenting concerns and psychiatric history, mental health history, then you say, okay, let's consider factors of race and culture. That's what I consider background. Foreground is just the opposite. You start with those elements of race and culture and background and context, and then you review psychiatric history and present symptomology. What do you think, background or foreground? Or does it even matter? Mixture of both. Say more about that. I like what you're saying, because what I believe I hear you saying, you said a mixture of both, means that you put that in the beginning and you put that cultural context all through your treatment and your experience. So it's interwoven. I like that. Other thoughts?
We have someone online that said, I believe culture should be foreground.
Culture should be foreground. Okay, so we're going to lead with that if we say culture foreground. Other thoughts?
If I could just remind folks in here, people online can't hear, so we'll bring the mic around if you raise your hand. We've gotten a couple of comments that they can't hear us.
Okay. Yeah, I like how you're thinking here, the thoughts that I've heard so far.
I'm wondering if one option would be to leave it up to the person you're working with of what they would want to start with.
To leave it up to your patient or your client to take the lead, would you say? To take the lead in bringing up those issues of race, culture, trauma, faith? She says not take the lead necessarily, but give them the choice of whether they want to talk about community and faith and culture. Yes, sir.
Can I try the background case?
You may certainly try the background case.
Here's what I would worry about. So if we think that psychopathology is similar to physical pathology, that we are all fundamentally very similar to one another, and that psychopathology is therefore mostly universal, that I would be led astray by over-focusing on culture. I would make the mistake of attributing to somebody's unique problem that it's more cultural than it actually is. And I might fail to treat an underlying universal problem that they share with everybody else. I don't think that's always true, but that's what I'm worried about with over-foregrounding.
So you're worried about overshadowing the clinical symptomatology with social and cultural factors?
Yeah, so imagine, to take it like a very simplified case, arachnophobia is probably less culturally bound than some of the more complex disorders that we deal with. And that if I think this is all about this person's background, rather than being about like fundamental Pavlovian conditioning processes, then I think treatment will risk being longer and less effective because I'm focusing on things that aren't the etiology of that person's problem.
Okay. Okay.
That's my fear.
Okay. Fair position. Thank you.
Thank you.
Others? I'll take one more.
Yeah, I believe it should be foreground in the sense that it should be patient-centered, and being patient-centered, you need to, get background information on the client culture so you can better assist them, because you want to make certain, your treatment plan is aligned with what the person's belief system is.
Okay, thank you. Thank you. Yes, we've got a mixed bag here, but I love the discussion. I love the positions that were presented because you all gave strong rationale and justification for your various positions. Let me proceed and share my perspective. Culture as background and this is purely my perspective, and this is a counseling perspective. Now, keep in mind, this is not per se strictly intended to represent a medical model, but I believe it is a shareable model. That culture, when treated as background, is seen as like this optional tangent that you could talk about or not. It is a background narrative seen as one of a lot of different options and directions that you could go in and things that you could consider in terms of how life is shaped. And you can choose, along with your client or patient, as the provider, to either reflect on those cultural issues or not. When I speak of culture as foreground, I'm suggesting here that culture then, for a particular case, becomes central and necessary information. That culture really is an overpowering foreground narrative. And what you might discuss in the delivery of service is a person's emotional problems in the context of something like domination or constraining self-definitions that are imposed by a way a person is socialized and by their life experience. You might discuss how a person feels alienated from their ethnic identity. You might discuss disempowering social forces as a factor in anxiety, as a factor in depression. You might explore post-traumatic stress disorder as being related to a racial related event, to racial discrimination. Okay, that's how I make the distinction. And let me move forward and say that I tend to lean toward foreground. Now, when I say I'm leaning toward foreground, I'm really agreeing with foreground and background. You start with an understanding of culture, and then you allow that to inform your entire patient-provider relationship. And the reasons for this are twofold. It has to do with visibility and validation, because members of marginalized groups have this experience of invisibility. Now, I know that seems not possible. How do you not see that I am a person with a darker hued skin tone? You cannot look at me and wonder if I self-describe as Black or African-American. You know, I'm going to probably self-describe as something in one of those categories: Afro-Caribbean, African-American, Indigenous African, something. I'm brown. So I'm not invisible to your physical eye, but I might be invisible in some ways to your clinical eye, because the lived experiences of people of color are generally outside the range of awareness for people who have never lived that reality. There's also the experience of invalidation, where Black, Indigenous, people of color, and many other, not just racially marginalized, but identity marginalized individuals have to function in an ethnocentric society that either intentionally or unintentionally invalidates their experience. I've had people say to me, well, LaVerne, I mean, look at you. You are accomplished and you've got education and you live in a nice neighborhood. You've never experienced racism, clearly. Invalidation without understanding that I've been told when I was selling a house to take my photos down so that prospective buyers wouldn't know a Black family lived there. I've been told where the neighborhood where I live is changing. Oh, what did you mean by that? And then she realized, oh, you must live there. Maybe I shouldn't say that, right? So invisibility simply being the experiences outside the range of awareness of those who don't live those experiences, and invalidation, literally invalidating one's experience as that identity. And when we all have multiple identities, we talk about intersectionality, as Dr. Kimberly Crenshaw coined that term, and we know that we all have many identities that intersect, but any one or all of a person's identities can be invalidated experientially by someone who doesn't understand. So we start, I believe, it's wise to start with, who is this person sitting before me when all of their identities, in fact, when I provide clinical supervision, I don't want my supervisees to come in and start with, I have a 35-year-old woman whose symptom presentation suggests generalized anxiety disorder. I want to hear, I have a Hispanic American woman whose English is not her first language. She is an immigrant from wherever. She is 35 years old. And then get into, because that gives me a context. It's so much different, right? I mean, if you say 35-year-old woman, what's the default? What's the default picture you get in your mind? Many times it's white, because white is the predominant culture, it's the predominant identity, it's where all things start, unless you give something more specific. So Visibility and validation are the reasons why I like to start with foreground, but it's not just in the front and then gets dropped off at the door. It stays at the forefront throughout one's entire realm of treatment. So the question then, the relevant question for the day, how do cultural and community context influence symptom interpretation, treatment, engagement, and patient communication? So let's go. Historical context shapes what we see in a number of ways because history includes collective trauma exposure. I am a descendant of enslaved ancestors, and I know that much of what I was taught by my grandmother, my mother and father, and others was influenced by what they were taught. And I'll tell you, my grandfather's mother, who is my great-grandmother, obviously, was born, check this out, just at the time when the Emancipation Proclamation was being signed. Hello. Do you not think that she taught her son, my grandfather, the rules of living as a Black man in the 1860s? He wasn't born until 1900, but she taught him how to live based on what she was taught. So there's any trauma that she experienced, it's not only been passed down epigenetically, but it's been passed down verbally in the form of survival rules, appropriate behavior, etc. Segregation and exclusion. My mother went to visit my relatives in North Carolina, when she was about 14. She was coming from Pittsburgh, Pennsylvania, and didn't know about segregated water fountains. So she turned around to go get a drink of water, was going to the fountain, chose the cleaner fountain, and did not think to look up. And when she went to drink from the whites-only water fountain, my mother, according to my mother's account of this story, alarmed the whole train station with, "Elizabeth, no, no, no." My mother tells me that story, and I wondered why she never went back to North Carolina to visit relatives ever again. I figured it out when I understood the importance of that story. Historical oppression, I could go on. Family survival narratives. That was a survival narrative right there, because what alarmed her was that when she almost drank from the water fountain and looked up in response to her mother's scream, she looked up and every eye in the entire train station was on her. Black, white, Hispanic, Asian, all eyes on her at 14. That was rattling for her. That was rattling. And by her refusal to ever return to that environment again, I'd say it was traumatic. Migration oppression. Family survival narratives, again, I shouldn't have that twice. Racial ethnic terror and violence. Medical exploitation. Mass incarceration. Economic exclusion. Earned distrust. And crimmigration, which is the criminalization of immigration. Just a few of the things. Short list, right? Not really. So if we're going to recognize those factors in the lives of marginalized, otherized, racialized populations, we need a way to identify the root of any dysfunction in our systems and in our thinking as providers. Now, I know we've got lots of trees. I have a trauma tree, and this is a I've derived this from my trauma tree. I derive my trauma tree from others, but this one is different. I doubt that you've seen one quite like this before. So let me start at the bottom with the roots. The roots of our delivery system allow for the pathologizing of survival skills. The roots of our provider system allow us to be rather judgmental and to place behavioral labels suggesting dysfunction on behaviors and choices that people simply have adapted for their own survival. Our system, unfortunately, allows the mislabeling of protective behaviors. Our system, unfortunately, often misses racialized stress. LaVerne, you've never been affected by racism, I'm sure. Look at you. Those kinds of things. And ignoring historical grief. The system allows for that, and that's unfortunate. Because that's where in our ethics codes, I know I'm a counselor and you're in medicine, but the ethics codes in one way or another always say, do not harm. Do no harm. If we are allowing our documentation, our diagnostic assessments, our case conceptualizations to pathologize survival skills, mislabel protective behaviors, misracialize stress, and ignore historical grief, we just may be doing some harm. So what do we have to do? After I call that exhuming the systemic bias. I call for provider accountability, where we reject inferiority biases and where we challenge cultural assumptions about deficits, deficiencies that are inherent, where we challenge stereotypes and generalizations as providers. We hold ourselves accountable and we hold others accountable. I believe that we must acknowledge cultural descriptors. I just list two here, things like historical grief, things like racialized grief, racialized stress. We identify those. They are not in DSM. And if you only look at DSM, I have nothing against DSM, but it can't stand alone. Your clinical judgment has to read DSM and say, I'm thinking about a person whose life has involved historical grief, racialized stress, whose life has involved stereotypes, whose life has involved a lot of overlooked factors. And I'm going to talk about the overlooked factors in just a minute, because that's the foundation of my book. We cannot make invisible, or we cannot invalidate racialized stressors, economic stressors, the effects of marginalization. At the top of the tree, you've got the roots, that's the systemic bias. The trunk would be provider accountability for those roots. The cultural descriptors are like the branches, but then, what we pay most attention to is the fruit, the leaves and the fruit at the top of the tree. Now, this is where we find symptoms. When I talk about this as in my other tree, I present the branches as the kind of like the diagnostic category, and then the leaves and the fruit as the diagnostic symptoms. But here, historical grief and racialized stress as the branches produces some fruit. They produce a threat detection intelligence. You all know about the central nervous system, and you all know, I'm sure, that the sympathetic nervous system goes into overdrive, so to speak, and this is the way a counselor explains it to our clients. So forgive me for not giving you the the brain stuff that goes along with that. But we understand that when a person has been under continual stress, not feeling safe, feeling perpetually endangered, when they've spent all their life running from a lion, even a squirrel looks like a lion. That's how I explain it. That's how I explain it to clients. Even a squirrel looks like a lion because of the hypervigilance, because of the increased sensitivity to danger. That is threat detection intelligence. I've been hurt before. I'm on high alert, so I don't allow myself to be hurt the same way again. Social pattern recognition. You develop a keen sensitivity to patterns related to what you can expect, how you're going to be treated, what's going to be offered to you, what you're going to be excluded from, where the microaggressions are going to come from, what the microaggressions actually mean. Adaptation, survival logic, boundary enforcement. I keep distance. Person keeps distance because a boundary feels like the only way to survive emotionally, psychologically, sometimes even physically. All kinds of protective strategies, identity preservation, data literacy. Now you say, oh, that sounds good. In a little bit, I'm going to show you how we unfortunately name those things in a way that pathologizes those things that when you look at it here, it makes perfect sense. All those resilient factors can easily be pathologized with our language. So the behavior of guardedness, when we write in our documentation that the person was resistant, we're not putting culture and identity first. If we put identity and culture first, instead of saying resistant, we'd call it perhaps a safety boundary. If we see behavior that would be described as hypervigilant, the traditional view says we document that as anxiety, but the culturally intelligent language might say threat adaptation. Self-reliance as a behavior might be documented as isolative behavior, when the reality is, from a culturally intelligent view, we can call it survival autonomy. This is why culture, identity, otherized identities, I believe, must involve the cultural lens first to avoid the traditional view of resistance and anxiety and isolation and such, which goes into a record, could be read by anybody in any system in a year, 2 years, 3 years. And when they read that record, they are reading that in the present and imposing your message about resistance and anxiety and isolation into their case conceptualization and their opinion or bias about the person sitting in front of them years later. We've done harm by placing a judgmental behavioral label on behavior that is actually a survival strength, because that's how they got to stay with us through if you see it through the eyes of their cultural lens. So in my book, I talk about the reasons why we miss so many culturally adaptive factors. I talk about overlooked identity issues, overlooked historical factors, overlooked clinical bias, overlooked losses, and overlooked strengths. The overlooked identity issues. I'll move through these quickly in the interest of time. Nomenclature, because every group whose heritage does not come from a Eurocentric background has gone through cycles of what they're going to be called in the United States. Mexican, Cuban, Hispanic, Latino, Latinx, darky, Negro, colored, Black, African American, Afro-American, back to African American, and that's just in my lifetime. Exoticism. You're so beautiful. What are you? If anybody's ever had that question asked, because a person views them as being exotic, whatever that means to describe a human being, I don't know. But it usually is often used in reference to people who have mixed race heritage and cannot be, so to speak, easily identified by certain phenotypic features. The 1870 wall is a reference back to 1870, which was the first US census where slaves or enslaved people, Black people, African people, were counted as individuals in their own right and were named in census records. I can't go back any further than, well, actually I could because I was willing to do the digging, but it's not easy to go back any further than about 1870 for people who are descendants of enslaved ancestors. In terms of names, tribal locations, all those things. And even when I do a ancestry.com and I'm told that my heritage is from Nigeria, well, Nigeria is the European designation for that geographical region. That does not describe my tribe, my clan. I have no knowledge of that. Now, there are some ancestry tools that are giving more detailed there, but that's brand new. That's brand new. So overlooked identity issues. And then lastly, the international standards of beauty and colorism. I don't think I have to describe that to you. We understand that European standards are viewed as the measure of beauty. Overlooked historical factors, colonialism, intergenerational hormone profiles. Real quick, the study that I'm referencing here is one where the descendants of Holocaust survivors had notably altered stress hormone profiles 3 and 4 generations later compared to their peers. I already said lions and squirrels. When you've been chased by lions, even a squirrel will cause you to run or fight or freeze or fawn. Overlooked clinical bias. Are we aiming clinical treatment at the right diagnostic target? One example, African American and Black men do not show up on depression scales as at a clinical level. And yet, in recent years, in my own family, I am a survivor of suicide loss in my family. Why? I think we've got to, I've read some studies that suggest that we need to rethink the questions that are asked so that they are more culturally nuanced and actually capture how Black and African American, Afro-Caribbean men experience feelings of defeat or depression or marginalization. We're gonna ask the questions that we're supposed to ask, but there are more questions that we need to ask, and those questions can be based on culture. Overlooked losses. Racialized communities tend to have shorter life expectancies. We have earlier exposure to loss. In other words, at a younger age, you are likely to have lost more first-degree relatives or close family, friends, and members than a person who does not come from a racially marginalized community. The loss of innocence, age overestimation, and presumed guilt. Real quick, age overestimation simply points to the fact that studies show that in children starting at about age, I want to say 5, the responses that Black children get to misbehavior puts those kids as expected to have the understanding of a 9-year-old. Oh, I thought he was older. I thought she was older. I thought she should know better. So therefore, the consequences of what is actually an age normative behavior don't fit. So we're punishing 5-year-olds or correcting 5-year-olds with the expectations of 9-year-old behavior. And that continues throughout the teenage years. And for the presumption of guilt, it goes in the kid's backpack. It's like they carry it every day. I'm going to be presumed guilty in class for something that I probably won't have done, and then I'll get in trouble if I get angry about that. Those are losses, loss of innocence. And then lastly, overlooked strengths, where we need to reverse the deficit narratives about Black and Brown and Indigenous and other communities and other groups. The deficit narratives simply come from Eurocentric standards being applied. And anything that does not match a Eurocentric standard then gets seen as toxic, dysfunctional, problematic. And the strengths of those communities then become overlooked. Another question, what does it mean to say that contextual clues can function as clinical information during assessment, formulation, and supervision? Well, we have to explore what happens when our assessments fall short. And I'm going to start with this. I have 3 case studies here. I'm only going to do one for the sake of time and for the emphasis on racial and cultural considerations. Malik is an 8-year-old second grader who his family describes as African American. His parents are upwardly mobile economically and professionally. One parent is a corporate executive, another parent is a successful attorney. Malik, in school and at home, presents with problems with emotional regulation, problems with task transition, and impulse control. The automatic or first ideas that come to mind, what you first think you need to screen for would be what? ADHD? Anything else? Anything in that realm. Some have suggested they would begin to screen for a spectrum disorder, something in the neurodiverse realm of treatment. And the problem with that, and Malik is going to an African-American male counselor, the problem with that is this. This is why I say culture first. Both of Malik's parents are describing as African-American, but Malik's mom, her water broke at 29 weeks. He was born at 32 weeks. Didn't go to full gestation of 39, 40 weeks. What population has the most known complications in childbirth and the greatest percentage of preterm births. I'm sorry? African American, yes, Black and African American women. What is one of the strong correlates for the children born at, say, between 8 and 12 weeks premature, preterm? You know? I'll tell you. Poor impulse control, emotional regulation problems, task transition. Why is that? Because in those last 8 weeks, we often focus on the lung development. And the obstetricians are happy to just have a live birth and to get those lungs strong enough. And we don't address the fact that the brain is also still developing in critical ways in those last 8, 10, 12 weeks. So what should have been developing in utero from a neurodevelopmental standpoint was then sort of postponed and is now trying to develop outside the womb, when that baby is also exposed to all kinds of things that his or her brain was not ready for. If you don't look at Malik as an African American, if you don't do the gestational history to determine if Malik was preterm, then you go with an automatic assumption toward something that is off base, because what we're talking about is neurodevelopmental, and interventions need to be introduced early on to give that child support because of the likelihood of these kinds of issues. So when you think about it, these issues are most often identified in first grade, second grade, third grade. Why? Because that's when those skills are called upon. At home, you can play and do other things, and we don't pay so much attention to the emotional dysregulation, and we don't pay too much attention to impulse control and task transfer and such. Those things become problematic in elementary school and continue by fourth grade. They can predict the school to prison pipeline, which says that by late adolescence, this child will likely begin to have problems with the legal system. Why? Because of emotional dysregulation, poor impulse control, difficulty with task transition, not to mention the trauma effects of not being white in a society where white is normalized. White is seen as the base, the standard. So when I asked this mom if Malik's counselor knew that he was born 8 weeks preterm, she said, no. I said, okay. So he needs to know that, and he needs to read the research on correlations between preterm births and those symptoms, because ADHD is different than this kind of neurodevelopmental pattern that we're talking about. This can be intervened at a young age, but we've got to start young. So we've got to start with obstetricians who are going to talk to parents about ways to support the brain development of a preterm child. We've got to talk to pediatricians about ways to support a child who is born preterm. We've got to talk to school teachers and guidance counselors. We've got to talk to social workers, got to talk to the police. We've got to talk to law enforcement, of course, I'm just police, law enforcement. We've got to talk to school administrators and guidance counselors. We've got to be having conversations that do not automatically put children in the ADH category, because how many of you know that we're African-American and Hispanic children are also most overrepresented in those categories, when the real problem could have been addressed with the right kind of brain development supports early on. I'm not going to do these other cases because I want to take questions. So let me move ahead. That was just one. There were a couple others, but that was one that I think is really important, because just as you weren't aware of the importance of those last 8 to 12 weeks in utero in terms of brain development, well, the research is there. It's been evolving. The studies have been evolving since about 2020, more in 2022, more in 2024. I encourage you to research that. Do some search, put some search terms out there about correlations, relationship between preterm births and these kinds of symptom presentations. We've got to know that culture is diagnostic context. And that's the point of the Malik case. Culture, racial identity is diagnostic context. Trauma can also be historical, coping can be ancestral, and mistrust can be protective, as you saw in my tree. So history is present in the room, needs to be present in the room from the start, and continue as present in the room throughout the course of care. If we're defining cultural misinterpretation, that occurs when that kind of context is absent. That occurs when cultural coping is pathologized. That occurs when the dominant norms define healthy. That occurs when survival behaviors are individualized and pathologized. I mentioned some of this before. Hypervigilance as anxiety, threat monitoring is what it really points to. Guardedness is seen as resistance when it's really boundary protection. Emotional suppression gets pathologized as avoidance when it's really safety regulation. Code switching gets pathologized as identity instability when it's really social navigation. I call PRN, personal race narrative use. Personal race narrative conversation is one that asks about a family history and a personal history of racial experiences in the people that we serve, in our patients and clients. It's a tool. If you would like information on that, I'll have my email available at the end. You can write to me and I'll send you a copy of the personal race narrative. It is not a clinical tool. It's a sociological tool that helps you to understand the life experiences from a race perspective of the person who's sitting in front of you. Questions?
Well, let's thank Dr. Collins for this very important conversation. As a reminder, if you have questions here in the auditorium, please raise your hand and the microphone will be brought over. But we do have a question online. How do clients respond when the cultural piece is included/addressed? Is it eye-opening?
Yes, it is. The question is, how do people respond?
When the cultural piece is included and or addressed?
When the cultural piece, some people actually come to tears because they feel seen. I will usually start a session with the question of, how are you as an African-American or Black male, Afro-Caribbean male, or woman, however they identify, how are you doing in today's world? They feel seen. I'm not just a face. You recognize that I'm carrying more than someone who does not look like me. So they love that. And so often I come to situations where when I involve those questions, we come to things that change the trajectory of the treatment. I was introduced to a middle-aged, well, a little older than middle-aged, my age, African-American woman who was struggling with anxiety in a workplace where there was constant change. And everything about it said generalized anxiety disorder. And that wouldn't have been a bad diagnosis, but it would have missed the cultural context of her being the first African-American child to integrate an all-white school when she was 9. The change that she had to endure, leaving her mother's school where her mother taught, and having her 5-year-old sister in tow, going into an environment where she knew there was the threat of danger. I call her Ruby Bridges without federal marshals. Ruby Bridges is the little girl that you often see in that artist rendering or in photos also with the federal marshals escorting her into a school that she was integrating by herself. This woman was a Ruby Bridges without those federal marshals, and she had her 5-year-old sister in tow. So now she works in an educational environment where there's constant change. And I ask those questions like, tell me about, I can see you grew up in the 60s and the 70s in a particular state. I bet you've got some experiences. I bet you've got some stories, any that you want to tell.
Any other questions in the auditorium? I have another question online.
Mm-hmm.
How might you create a safe space for someone to feel comfortable to open up and disclose information about their culture?
Simply by asking a general question. This question is, how do you get started? How do you broach that? Starting out with, as I suggested, how are you as an African-American woman doing in these times, in today's culture, in today's world? How are you doing? Or with the other case that I suggested, I can see you were at the time period you were born and where you were raised, where you grew up. I bet you've got some experiences. Or how are you as, and then again, whatever identity, doing at a time when, and then you place it into context. I could speak to a person about gender norms, gender identity, and say, how are you doing at a time whenever the way that you identify is not being recognized any longer?
We have 2 final questions, at least online. Thank you so much, Dr. LaVerne. I appreciate your sharing and wisdom. How can we get your book?
Oh, the book is available on Amazon.com and also through Rowman and Littlefield Publishing, now Bloomsbury. The publisher changed names.
Okay, and our final question, please comment on how this cultural awareness is applied beyond assessment, i.e. in treatment.
Great question. How is this cultural awareness applied beyond assessment, but also in treatment? You'll recognize, if you ask, and that's the key, to ask, are there certain resources and supports that are important to you that I may not think of, that I may not be aware of? That way you invite the use of their cultural resources, their faith resources or community resources or whatever they may choose. Or there's certain things that are not going to be comfortable for you. Or there's certain things that you want me to include. And I guess the other thing I would say would be to, and it just left me that quick, inquire. See, when you get to be this age, you can't hold on to a thought for 30 seconds. Follow the person in the moment. I'll say that. Follow the person in the moment and ask what feels natural. But the important thing is that you establish that relationship early on where you let them know that it's safe for them to bring that content to you. That's up to you. The research says that the provider's responsibility, when a provider broaches this content first. It causes the client or the patient to feel safe. You are the authority. And many times people are afraid of being judged, so they won't bring something up. But if you make space that lets them know that it's safe, you can ask them what kinds of interventions they prefer, what's safe, what kinds of things should be included or excluded. So.
Well, thank you. Thank you for your answers, for your time. For those of you that have stayed, thank you. We do have a couple more questions that have come in, but unfortunately we cannot get to those. Join me again in thanking Dr. Collins for her time with us here today.